This is the clinical core protocol training for TRACK-TBI, the Transforming Research and Clinical Knowledge in Traumatic Brain Injury Study. This is part 1. My name is Jeff Manley and I am the contact PI for TRACK-TBI. In our training outline, in part 1, we will give a background for the TRACK-TBI study and we'll discuss the study design and enrollment targets. In part 2, we'll discuss subject screening and enrollment procedures. We'll talk about procedures by core and the importance of follow-up and subject retention. TRACK-TBI has 11 study sites across the United States. These represent some of the premier TBI research centers in America. We also have 9 additional collaborative sites that are part of this study for data analysis. TRACK-TBI is also part of the International TBI Research Initiative, which is a rapidly evolving international TBI effort that involves our partners in the EU, including Centre TBI, and our Canadian partners that are represented by several studies across Canada, and also with our pediatric partners with the ADAPT study. We're also evolving with studies being planned now in Australia, China, and India. TRACK-TBI builds on the success of the TRACK-TBI pilot, which enrolled 650 patients over about a year period of time several years ago. In this study, we demonstrated the feasibility of the TBI CDEs, and we started to create infrastructure for data collection systems, databases, and protocols. And there were many lessons learned. We've tried to use these lessons learned to improve this study today, which we are calling TRACK-TBI. The goals of TRACK-TBI are to improve TBI diagnosis and classification, or a taxonomy of how we describe traumatic brain injury. We also are setting out to improve TBI outcome assessment to move beyond the GOSE. This will require a lot of work on the part of the sites in terms of follow-up and the outcome batteries, but we believe that this will greatly improve our long-term ability to conduct important clinical trials in traumatic brain injury. We're also going to identify health and economic impacts of mild TBI in terms of patient disposition. And ultimately, we will create an information commons to promote collaboration and acceleration of TBI research, not only for the TRACK-TBI research team, but hopefully for generations of TBI researchers to come. This figure describes the data flow for the TRACK-TBI study. We will have clinical data that is collected with site QC, which the folks at each individual site with the PIs and the coordinators will be responsible for. We'll have an imaging flow where there will also be site QC that comes from the magnets back to Loney. And then we'll have biospecimens where there will be another additional training video describing in detail how the biospecimens will be processed, shipped, and stored. As you can see, we move through a data collection, transport, a curation step, and ultimately this data will be integrated and uploaded into Fitbur, and also with some of our other informatics partners such as the OneMind portal. For study design and enrollment targets, our subject groups consist of a total of 2,700 TBI patients to be enrolled across 3 clinical groups. We are stratifying patients for this study not by coma score, but by the type of care that they received. So we'll enroll 900 patients that were only seen in the emergency department and then discharged. We'll be looking at another 900 patients that were admitted to the hospital, but not to the ICU, and this is what we refer to as the admission group. We'll also look at 900 patients that were admitted to the ICU, and these are called the ICU group. The aim is to enroll even numbers across these groups. However, we understand that some sites may not be able to enroll evenly due to variations in practice. For example, in some centers, we understand that patients are either discharged from the emergency department or they're frequently then just admitted to the ICU for overnight observation. Understanding this, we've worked out a policy by which for each quarter that you're trying to enroll the patients, we want to enroll evenly into each group unless with your particular hospital, you don't have the ability to do this, and then we will resort these to either the emergency department group or the ICU group. We will also have 100 controls per group with extracranial trauma for outcome assessment and testing. Enrollment of this group is going to be deferred until we complete enrollment for the CI, for what we refer to as the CA, which is the comprehensive assessment, and the MRI cohort. So we don't have to worry about this in the first year of the study. The 3 subject assessment cohorts are the brief assessment group, and in this cohort we will have 1,200 patients. The enrollment for this will start in year 3, quarter 2. The comprehensive assessment, which we just referred to, represents 1,200 patients, and we will be enrolling these patients in years 1 to 4. These patients will be getting the most robust data collection, not only in the acute period, but also with respect to repeat biospecimen retrieval and extensive outcome assessment. The last group, which will be the first group that we will be targeting in this study, is what we refer to as the Comprehensive Assessment CA plus MRI. This represents 600 patients. We will be enrolling these patients during years 1 to 2. All of these patients are initially enrolled into this group, as it is anticipated that only about 33% will complete this MRI as planned, and these patients will then be allocated to the CA if they will only do the in-person assessments. So again, this will be the first group that we will be enrolling, and it is important because they will be the most comprehensive, not only with respect to the baseline data collection, biospecimens, and outcomes, but they will also be getting MRI scans at 2 weeks and 6 months. This is a chart looking at the single-site quarterly enrollment targets, and what this represents is how in years 1 and 2 we will primarily be looking at the CA plus MRI and the CA group. The brief assessment group will come later in the study, as we described earlier. This is a panel from our data collection system and data management system that we are using for TRACK-TBI called Question. Many of you may have already participated in some of the Question training webinars, and these are also available online for a refresher. There will also be additional Question training through the beginning of the study and at repeated intervals as new study personnel are added. In meeting the quarterly enrollment targets, the NINDS has required that the sites achieve 80% of their accrual targets. If a site falls below 80% of their enrollment target at the end of the first 2 quarters of the enrollment, the executive committee will consider reallocation of the patients in the shortfall to other sites that have met or exceeded the targets, beginning with the highest performing sites. Our experience with the TRACK-TBI pilot was that there were many patients that were candidates for a study such as this, and we anticipate with good screening and aggressive follow-up that people will be able to achieve their 80% of their accrual targets. At the end of the 3rd quarter of enrollment, if a site does, though, continue to fall short of the 80% target, no new patients will be enrolled, and the executive committee will reallocate the subjects to other sites that have been meeting these goals, again beginning with the highest enrollment sites first. We have been required by the NINDS for this study, because this is a contract with NINDS, that we need to have milestone payments. The site grant administrators will need to generate invoices in conjunction with the study coordinator to determine which milestones are due for payment. Each milestone is eligible for invoicing upon completion, and the Question dashboards which we've built will assist with figuring out payments due for each site. Invoices can be submitted monthly, bi-monthly, or quarterly depending upon the site preferences. However, we would prefer quarterly submission. UCSF grant analysts dedicated to the U01 grant work will work with these sites to confirm the payment that's due per their milestone component and for their study study expenses. We understand that this may be complicated, and this was required by the confines of how this grant was funded, and we will do our best, and we hopefully have the resources to make this as easy as possible, period. This gives a sense of the performance milestones, and the reimbursement for each of the groups. Again, remember the CA plus MRI is our first enrollment group where we will have a comprehensive assessment plus MRI. The comprehensive assessment patients do not get the MRI, and then we have the brief assessment patients. So for enrollment in blood draw, each one of these groups will receive $1,000. For the follow-up blood draws and weekly outcomes, you can see in this chart how the figures add up to get a total by cohort. This is essentially what is termed as a pay-for-performance strategy. This shows you an example of an enrollment dashboard on the question site, and we will have these dashboards available so that one can compare their performance to the other sites. We expect there will be a robust competition for who can get there the fastest in each quarter, and it will allow you to not only look at your performance but the performance of others. This also gives you another example of a quarterly invoicing report with an example of 100% milestone targets met. So as you can see in quarter one and in quarter two, we have enrollment, we have follow-up, meeting all of the milestones of the study, resulting in complete payment as outlined in the subaward budgets for performance in the TRACK-TBI study. In terms of screening and enrollment, let's talk about subject identification first. All eligible patients must receive an acute clinical brain CT due to an external force trauma to the head. These are essentially people with a history of brain injury or head trauma that have been deemed by the emergency room staff to require a head CT. For the ED patients, the ideal place to begin screening is scanning for acute scheduled or recently completed within the enrollment window, which is less than 24 hours from the time of the original injury, for CT brain studies in the radiology department. For admitted or ICU patients, medical record reviews may be needed to confirm completion of the CT scan. As with all of these studies, a good relationship with the clinical team is important in terms of proper patient identification. There's a three-stage screening process. First, there will be a review of the medical records and test results to determine eligibility. Subject interview will then proceed to present and discuss this research participation opportunity. Subject completion of a screening evaluation to determine competency to provide informed consent. Only after all three of these phases have been completed would the subject be asked to participate and provide formal, signed, informed consent. So to review, we want to make sure that the patients meet the eligibility criteria, that the subject is interested in participating in the research, and that we complete the screening evaluation to determine the competency for the individual to provide informed consent. With respect to subject eligibility, to dig into this a little bit deeper, we will enroll adult patients of all ages presenting to the emergency department with a history of acute closed TBI per the ACRM criteria manifested by at least one of the following: any period of loss of consciousness, any loss of memory for the events, amnesia immediately before or after the accident, any alteration of mental state at the time of the accident, feeling dazed, disoriented, or confused, or a focal neurological deficit that may or may not be permanent. As you can see, this is a very broad inclusion criteria, and this is done on purpose because we found that there were patients who actually just had an alteration of mental state, feeling dazed, who we went on to find many important things with respect to MRI imaging, biomarkers, etc. This is the inclusion criteria that you can find in the clinical protocol. So we're looking at all ages from 0 to 100. However, only 2 of the sites currently are specializing in enrolling children. Most of the sites at this point are focusing on the adult population. Again, documented or verified TBI by the ACRM criteria, an injury that occurred within 24 hours, an acute brain CT that was ordered for clinical care, visual acuity, hearing that is adequate for testing, fluency in English or Spanish, and the Spanish refers to sites with the personnel to do this. If you do not have Spanish-speaking personnel, you're not required to enroll Spanish-speaking patients. And the ability to inform consent, which is obtained through the interview. The exclusion criteria is any significant polytrauma that would interfere with the 2-week follow-up and outcome assessment. somebody that's a prisoner or a patient that's in custody, pregnancy in female subjects, and patients that are on psychiatric hold, for example, a 5150. Also, a very important aspect of this that we learned in the TRACK-TBI study is that patients with major debilitating baseline mental health disorders, such as schizophrenia or bipolar disorder that's uncontrolled, that would interfere with the follow-up and the validity of the outcome assessment will be excluded from this study. We're also excluding major debilitating neurological disease, such as stroke, dementia, or a brain tumor, impairing the baseline awareness, cognition, or validity of follow-up and outcome assessment. And this can really be determined from the chart and from the interview. And probably the most important part is a significant history of pre-existing conditions that would interfere with follow-up and outcome assessment, such as substance abuse, severe alcoholism, end-stage cancer, learning disabilities, and developmental disorders. Again, we're trying to be as inclusive as possible with this study, but we understand from our experience in the TRACK-TBI pilot that patients with substance abuse and uncontrolled alcoholism really have a difficult time following up, and that's not the purpose of this study, as we are really focusing on obtaining outcome assessment at 2 weeks, 3 months, 6 months, and a year, as well as in the initial 600 patients obtaining MRI scans. Speaking of MRI scans, one of the contraindications for the first group of patients, which we call the CA plus MRI cohort, is contraindications to an MRI. Point 9 continues with the earlier discussion, which is a low likelihood of follow-up. If the participant or family indicates a low interest, if they're a resident in another state or country, or if they're homeless with a lack of reliable contacts, this is probably not the patient to enroll in this study, because there's going to be a lot of time and effort that's going to be dedicated to the upfront data collection, and the outcomes are ultimately one of the most important things that we will collect. And if we can't get follow-up, the value of that early data becomes less and less over time. Also, people that are currently participating in an interventional trial, such as a drug or device trial, are not eligible for this. And we are also excluding patients with penetrating TBI. In terms of evaluation for competency, the medical record should be reviewed to determine whether or not the subject has been diagnosed with post-traumatic amnesia or other cognitive deficits that wouldn't allow them to consent. The subject and family, if present, will be approached and informed about the study. If the subject and family agree, the GOAT will be administered according to the standard procedures. Anyone with a GOAT greater than or equal to 75 is competent. A GOAT less than 75, then informed consent must be provided by an LAR. In terms of the clinical core, the study coordinator responsibilities really have a central role in assuring patient retention to complete the outcome and imaging assessment milestones. This really can't be underscored enough. The key to this study is developing a good relationship with the subjects up front, following up with them, and making sure that they understand the importance of getting this long-term follow-up information. This is not an easy study, and often it will require multiple phone calls to get these patients back for follow-up. In fact, some of the patients in the TRACK-TBI study required at least 20 phone calls. So we understand that this is a challenging study, but the better relationships that one creates with the patient up front, the more likelihood that you'll have with follow-up. And again, picking the right patients the first time to make sure that people are enthusiastic and motivated to come back. Also, you're required to maintain current entries in the question patient management menu for tracking contacts, scheduling follow-up visits, transport, and reimbursements. This is how we can help to monitor this with our dashboards to make sure that we're staying on track. With respect to the tracking contacts, you can't get enough information from a patient to figure out where to find them. You need to get numbers from telephone. You have to get telephone numbers from friends, from relatives, from where they're staying. Again, we found that the more contact points that we have, and the more telephone numbers we have, and the more email addresses we have, the more likely we are to be able to follow up with the patient. And ask the subject, how would you like to be contacted? Do you prefer getting a text? Do you prefer getting an email? Do you prefer that we call a relative or a caretaker? Again, this is absolutely crucial to the success of this study. When we assure the compliance and retention, every effort needs to be made, again, to schedule return visits at the subject's convenience, and multiple procedures for that time point will be scheduled on the same day if feasible for the location and the patient tolerance. When they return for their follow-up visit, they will be met by research personnel who will escort them to the various testing locations. Subjects will have full opportunity to ask any questions before, during, and at the end of the follow-up appointment. Site coordinators are encouraged to have relevant resource packets and materials for TBI assembled to provide to the study patients. Again, this is all about developing rapport with the subjects to ensure that they will continue to follow up with us over time. In terms of different retention scenarios, loss of an incomplete CA plus MRI follow-up. So if the subject doesn't or can't return for a 2-week for a 2-week MRI, you need to attempt to go ahead and schedule this person for an in-person CA visit. So oftentimes people will be willing to come back for outcome assessment at the 2 weeks, but they will not be able to come back for the MRI. They just simply are nauseous, they don't feel well enough, where they can be tested on some level, but they don't really want to be in an MRI. For those patients that can't tolerate an MRI at the 2 weeks, then they will drop down into that CA group. Again, we want to try to get MRIs in every one of the first 600 patients, but we understand that some of these patients will not be able to get that 2-week MRI, and if they're not, then they drop down, so to speak, to the CA group. If the subject can't return to any of the CA visits, we should really try to attempt a telephone interview with those tests that are suitable at 2 weeks, 3, 6, and 12 months, and we will provide you with a battery for telephone assessment. If a subject can't or return, if a subject can't or won't return for all or any of the CA visits, again, we want to attempt a telephone interview with those that are suitable at the 2 weeks, 3, 6, and 12 months. In terms of data collection and management, more in-depth training on the ECRFs will be provided in question with the training forms that are populated according to the ED, admission, and ICU enrollment groups, and those will be scheduled in the near future. Hard copy CRFs need to be entered into the question in a timely manner, as weekly form status will be generated for each subject and site. So essentially, if the data isn't entered into question, it's not collected, and we will be looking for form completeness and be giving reports back to the sites, so timely entry of the data is crucial. Decision to generate the GUAs, or these unique identifiers for these patients via question, is going to be site dependent, and the procedure will be addressed at a later date with each site. Data quality audits will be conducted for each site by an external team from Baylor. With respect to the biospecimens core, a study coordinator will be responsible for obtaining and coordinating blood specimen collection at enrollment, where we will get serum, plasma, RNA, and DNA. And again, there will be a separate training video, and there is a protocol detailed for this process. Also, for folks that are in the hospitals at day 2 and 5 for the admission in the ICU group, they will also be getting serum and plasma. The 2-week and 6-month time points, we will be getting serum, plasma, and RNA. This completes the part 1 of the clinical core protocol training. Please now proceed to part 2 of the clinical core protocol training. Thank you for your attention and your participation in TRACK-TBI.